Hello and welcome. This is the Sight and Sound webinar series from the Jymirah Foundation called Sight and Sound Bites. This is a bi-weekly webinar series which started in April 2020, and we highlight the research at the University of Pittsburgh School of Medicine for the departments of ophthalmology and otolaryngology. So today's topic is exploring novel pathways to provide care for people in need. I'm Lawton Snyder, CEO of the Jymirah Foundation. The Jymirah Foundation supports research to advance care for vision, hearing, balanced voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Jymirah Foundation to support research are only made possible because of philanthropic support. I'd like to thank everybody who has been supporting the Jymirah Foundation over the years who've joined us today, but also thank those who would consider that doing so in the future. For today's program, the chat is disabled. We want people to know that because you're used to using Zoom, and that's one thing people like to do on Zoom. But for this, we will have question and answer function available. So when you want to ask a question, please put it into the Q&A section right on the bottom bubble on your screen. Refrain, please, from asking personal health questions, but you can put them in there and we can make sure we get to them eventually, but I may skip ones that I think the rest of the group may not be interested in. We will send you a survey tomorrow. We appreciate people completing the survey and giving us their feedback, and we'll be adding you to our email list for future webinars. Today's speakers I'm going to introduce our chairman to introduce the speakers, I should say, is Dr. Jonas Johnson, Distinguished Service Professor and Chairman of the Department of Otolaryngology and the Eugene N. Myers Endowed Chair at the University of Pittsburgh School of Medicine. Dr. Johnson, thank you, and we're looking forward to a really interesting program today.
So thank you, Lonnie, and welcome everyone who's joined us on this webinar. So we've titled today's presentation, Exploring Novel Pathways to Provide Care to People in Need. So I don't have to tell you that the year 2020 has been provocative. The events of this year have caused us all to be more aware of healthcare disparities, of social justice, and the social determinants of health. So I want you to know that our department has been invested in such things for some years now. And we are going to address this in two ways. The first way is going to be a presentation by Dr. Catherine Palmer, who's the Director of Audiology here. So Catherine has for many years been a great proponent of hearing preservation. And of course, Catherine understands that if you lack hearing or you're hard of hearing, it interferes socially, but it also probably accelerates the development of dementia. So to reach out to people who are have hearing loss and provide them some aid is so important. So Dr. Palmer is not actually going to be with us today because of a death in her family, but she was very gracious and she has recorded her presentation. So let's go forward and show Catherine.
Good afternoon. I'm Catherine Palmer. I serve as the Director of Audiology for UPMC, and I'm thrilled to be here today to talk about Hear Up, hearing education and resources for underserved populations as part of our discussion of exploring novel pathways to provide care to people in need. When we think about humanitarian audiology in our field, it really brings to mind images of overseas missions all over the world. But really, there's need right in our own community, in our own backyard. And that's where we've focused this program. Lack of insurance isn't the issue in terms of hearing aid access because generally hearing aids aren't covered by insurance. So we often think about underserved populations and focus on insurance issues, but this is a situation where having insurance actually wouldn't be helpful at this time. We're very lucky in the state of Pennsylvania that children under the age of 21 receive hearing aids for free, regardless of income. That allows us to provide excellent care for this population as they navigate school, education, and start to get into the workforce. Our Children's Hospital provides that care here in southwestern Pennsylvania. Unfortunately, after 21, many of these individuals will fall through the cracks if they don't have income in order to continue to get hearing aids as they need them. One would typically expect to need to replace hearing aids about every 5 years. The average price of a hearing aid in the U.S. is $2,400. We work very hard at UPMC to keep prices as low as possible, but the reality is they're still really very expensive. So people below the poverty level and really even 200% above the poverty level are going to be in a position not to be able to afford what is really essential. Untreated hearing loss is associated with a myriad of issues, including low educational attainment, low income, and underemployment, including many people with untreated hearing loss in working age years have an annual income less than $20,000. It's associated with unemployment, and in fact, this group has 2 times the odds of unemployment, and social isolation, depression, and anxiety. In essence, untreated hearing loss has a severe human cost and also a societal cost. There are a number of barriers to accessing hearing health care, and I want to describe several because I think we all think about cost, and that's certainly true. For many individuals, hearing aids will be the 3rd largest purchase that person makes in their lifetime after their home and car. And as I said, they're generally not covered by insurance and certainly not for adults in Pennsylvania. There's also barriers in navigating assistance because there are some programs to try to assist people in getting hearing aid technology and the services that go with that. But access to the programs and the paperwork can be a problem for people with a variety of challenges. Literacy can be a challenge in completing this paperwork. And the lack of a permanent address is a barrier to accessing programs that need to reach you continually by mail or by email. So lack of that access as well is a barrier. And then language can be a barrier for new immigrants and refugees. They may not have any English at all, so accessing these programs becomes impossible. And English as a second language can continue to be a barrier to access these programs and, of course, to also gain employment and take advantage of why you've come to the United States. So we put together a team, and we'll start with UPMC audiology and otolaryngology. Otolaryngology, one, because when you think of total health care, for some of the people we see, they may need a physician, and our physicians go to the Birmingham Free Clinic every few months, so that's very helpful. But specifically, otolaryngology in terms of Dr. Johnson being supportive, because of course these programs require resources right from the department. So we had a commitment from Dr. Johnson and from the audiologists that they wanted to do something about this problem. We decided to team up with the University of Pittsburgh AUD program, so the program where we train audiologists, thinking that this would be a wonderful service learning opportunity for those students if they worked with us in these clinics. And then, of course, the Eye and Ear Foundation is essential, or this program doesn't even get off the ground, because this requires funds, of course, to provide the technology. We, as a department, provide all of the services for free, but there's a physical cost to the hearing aid technology and to the batteries that run these hearing aids. And then we needed an industry partner who was willing to give us the best possible pricing, so our foundation donations could go as far as possible. And then we teamed up with the Schweitzer Foundation, and this was the idea of Elaine Mormer, who's at the University of Pittsburgh and coordinates the clinical practicum for those students. Ours were the first audiology students ever to receive Schweitzer fellowships, We've now had 9 Schweitzer fellows, all involved in the Hear Up program specifically. And so they continue to team up with us to provide this care and to expand the care. We first teamed up with the Birmingham Free Clinic in 2016. So that's an established clinic on the south side of Pittsburgh. And then in 2017, we expanded to the Squirrel Hill Health Center. And I can talk a little bit about the differences in those programs in a minute. So we had the team, and then the goal was really to provide guerrilla audiology, which means providing same-day care. This is really uncommon. A typical getting a hearing aid requires an appointment where you're going to have an evaluation. You're going to discuss what you want to do. We'll take ear mold impressions. Those have to be sent away. In a few weeks, they'll come back, and we will have ordered the hearing aid. It'll be in. And then we can fit the hearing aid, teach people how to use it. And then usually there's at least one more appointment to do any fine tuning. And then people can see us as needed after that. So our goal was to do that all in one day. So that required just some thinking differently about how we do things. So we do the hearing test, and then we already have the hearing aids. We use behind the ear hearing aids so we can fit people the same day. And we make instant ear molds, which was a whole new technique for us to learn that's certainly paid off in these clinics and in some of our other clinics as well. And then our other part of this was we needed these individuals to have access to free batteries all month long. So we come into these clinics once a month to do this work, and then we work with the clinics to have the free batteries available at the front desk for individuals. Part of our goal here was based on our concern that some of the individuals accessing, especially the Birmingham Free Clinic, might not come back and might not have the ability to come back, and all sorts of different things can, kind of be barriers for them continuing to access care. So we felt like if they could get to us, we really wanted to do everything right then and there, if at all possible. And we've been able to do that. I thought you might just enjoy some pictures. This is the Birmingham Free Clinic. And the top picture, if you look at the top right corner in the back, that's the little room we practice out of. We bring everything in a suitcase, set up and work for the day, and then clear out when we're done. The bottom left is showing you the front office, which is where people can come in and get hearing aid batteries whenever they need them. And I show you the bottom right-hand corner because the Birmingham Free Clinic just moved into the Roche Taylor building, which is right next to UPMC Marci Southside. So it's in a nice new fresh space, which is very nice for everybody. And the Squirrel Hill Health Center is a little bit different. It's a federally qualified health clinic. So this is a clinic that's funded by the federal government and typically serves individuals who are going to have Medicaid. And specifically, what was interesting in Squirrel Hill Health Center is that they serve the immigrants and refugees that come into Pittsburgh. So those individuals have about 8 months of Medicaid. The Squirrel Hill Health Center has primary care physicians who try to manage their care and get them everything they're going to need to be successful here in the U.S. And then on the right side, you just see some pictures of Dr. Mormer, one of our supervisors, and some of our Schweitzer fellows who've been involved in this program. So what's happened so far in these two clinics, I just thought I'd share a few numbers. We've had 325 scheduled appointments over the last few years when we've been in these clinics. We have about a 20% no-show rate, which means we've had about 260 actual appointments with people. We've seen 107 unique individuals within these appointments. So the first thing that jumps out to you is these individuals do come back for follow-up appointments, and we've been really actually thrilled by that. So people have been very successful with their hearing aids, and if a hearing aid isn't working and they need repair or help, they come back in right away to get that assistance, which we've been thrilled with that result. We've done 104 hearing tests, and 95 individuals who've needed hearing aids have received them at no charge. And so this is a total of 190 hearing aids, and typically people get 2 hearing aids because that's how we hear a noise. It's how we localize and know where things are coming from. People do come in for follow-up appointments, and again, they come in whenever they need to get batteries. The comments from our patients are just so motivating and just very rewarding for the supervisors and the students. In our Squirrel Hill location, We're meeting people who have worked very hard to come to this country, often speaking no English at all. And if you picture that room I showed you that we work in, we'll meet people and we'll have a patient who has severe hearing loss who doesn't speak English, and often a younger family member who doesn't speak English. And we use what's called a blue phone, so we can have a translator. So then we have a translator translating us to the younger person who can hear, and then they get the translation and say it to their family member with hearing loss. And that's all happening in that first appointment. And then we fit the hearing aids. And when these people immediately are aware that suddenly the world has opened up for them, we say we measure our success now in smiles in this population. We notice people suddenly are, talking more than they did before, talking to their own family, and often we'll see them a month later, and they're starting to talk to us in English, and they are being able to tell us what's happening in their lives. And our patients in the Birmingham Free Clinic, this is a group, tends to be, it could be unemployed trying to seek employment, or people who are underemployed. We will see some homeless individuals in this population. This is a very grateful population who tells us what it means to hear. And that seems so obvious, yet it's something that isn't accessible to them until this clinic. So they'll tell us of being able to keep jobs they were worried about losing, being able to have job interviews and be successful, feel safer as they navigate the streets because they can hear their environment and react to things going on around them. Thanks so much for your interest in our Hear Up program. I appreciate the opportunity to describe it to you, and I will hand it back to Dr. Johnson.
Okay, Dr. Johnson was having some technical problems, but Dr. Johnson, do you have those resolved? If not, I'll go ahead and introduce our next two speakers. So first, I'd like to introduce Dr. Marci Nilsen, who is a PhD in the School of Nursing, and is also, there he is. Dr. Johnson, I was just about to do your job for you, but you came back. Oh, maybe he doesn't have audio yet, though, so we'll give him a second. And then we're also very pleased to have Jymirah Morris with us. Jymirah is a student in the University of Pittsburgh Medical School. So Dr. Nilsen, please take it away.
Hello, I'm going to, thank you. We're going to run through a couple slides real quick. So one of the things that we do is the University of Pittsburgh Department of Otolaryngology has founded the UPMC Head and Neck Cancer Survivorship Clinic. And this started in 2016. And the goal was really to provide patients with an easy way to address their symptoms and their side effects of treatment by seeing a multitude of providers in one location. And so this clinic was set up so that we would have a surgeon, a nurse, an audiology assistant who is from Dr. Palmer. She's graciously given us Lizzie, and she screens all of our patients' hearing. An SLP is a speech language pathologist or a swallowing therapist, a physical therapist, a dentist, a dietitian from Hillman, and a clinical psychologist. And so all of these providers are in one place. They're in one clinic, and so a patient can see them. And the visit takes about 30 minutes to an hour, and it does have one copay. So we wanted to try to minimize the financial burden for patients, because if you were to see at least most of these providers separately, that would come with an individual copay, which could lead up to $200 to $250 for just one visit. And so what we do is head and neck cancer. And head and neck cancer is a variety of sites in the mouth and the throat, in the voice box. And patients who come in with head and neck cancer usually have cancer that's also in their neck. So in not just their primary site, but a spot in their neck. And so this requires patients to have several different treatment methods. And this can be a really difficult time for patients to navigate the system. They have 3 or 4 providers. They're getting multiple treatment, whether it's chemo or radiation and surgery. And we know that there are factors that affect a patient's ability to navigate or access the system. And it also, in the end, can impact overall outcomes such as quality of life, how long they live, how many hospital stays they have before and after treatment, and even just the amount of money that is spent on their treatment. And so Jymirah Morris has been working with us for the last several months, and she's really interested in how these factors impact our head and neck cancer patients and their loved ones who care for them. And so she's going to introduce some of these ideas and factors that affect patients' ability to access and navigate the system.
So good afternoon, everyone. As Dr. Nilsen said, my name is Jymirah Morris, and I'm going to start off this presentation with just asking everyone to look at the slide in front of you. And if you could put in the Q&A section, just one thing that you identify as a potential health disparity. And then I'm going to go ahead and talk you through this slide. And so, disparities, when we talk about disparities, they're everywhere. There are powerful, very complex relationships that exist between health and biology, genetics, individual behavior, between health and health services, socioeconomic status, physical environment, discrimination, racism, literacy levels, and even legislative policies. So on this slide, we've got things like sexual orientation, we've got education status, access to food, rurality. So if someone lives in an urban setting versus a rural setting, we've got a little barn here, access to clean water and transportation. And all of those play a factor in determining health. So here, this is a health impact pyramid, which really looks at how different clinical actions have impacts on patients. The greatest health impact, as we see at the very bottom, will likely come from interventions that address socioeconomic factors, because these factors drive disparities across multiple conditions. Some of those socioeconomic factors that I mentioned include access to care, high quality education, nutritious food, decent and safe housing, affordable, reliable public transportation, culturally sensitive health providers. So as Dr. Palmer mentioned, it's important to have a healthcare provider that understands that everyone who comes into the clinic will not speak the same language that we do. Health insurance, clean water, and non-polluted air are just some examples of those socioeconomic factors. Next on this pyramid of health impact, we have different environmental kind of interventions. And these are things that really change the environmental context to make healthy options the default choice, regardless of education, income, service provision, or other societal factors. With this particular level of impact, people have to really expend significant effort to not benefit from them. Some examples that you may or may not be aware of are fluoride in water or iodine in salt. Again, clean water and air. Obviously, there are some areas that don't benefit from that as equally, but if you do have clean air and water in your region, that's not necessarily something that you've had to expend too much energy to benefit from. The elimination of lead and asbestos in homes and seatbelts in cars. If you all can think about these examples, all of us benefit from them in some kind of way, but that entailed really little to no effort on our parts. The next tier, so to speak, of this pyramid are protective interventions. So that would be a one-time or infrequent interventions. We can think of this as maybe like an immunization. So immunizations prevent 2.5 million deaths per year among children globally. But as we see, as we're going up this pyramid, this is something that has maybe a little bit less impact because it requires reaching people on individual levels as opposed to collectively. Another example would be screenings. So blood pressure screenings or colonoscopies, these are kind of clinical interventions or actions that can significantly reduce a patient's morbidity or, reduce colon cancer. And these kinds of interventions are really only needed every 5 to 10 years for most people. But again, that involves getting people to go on individual levels. In the world of ENT, that might include like oral cancer screenings, which absolutely could reduce the incidences of head and neck cancer. However, the data is a little mixed about the frequency and universality of these screenings. So as we see, there's a little bit more individual effort needed as we're going up this pyramid. The next tier would be ongoing clinical interventions. And these are actions on the part of the healthcare team that prolong life and reduce disabilities. So over the years, typically what's happened is that the efforts to eliminate healthcare disparities and achieve health equity have really focused on this particular tier of the pyramid. And so as you can see, examples include medications and lifestyle changes, diet changes, things that people don't really want to do. However, this level particularly is impacted heavily by access to those particular diets or adherence to certain clinical recommendations. Everyone doesn't do everything that they are advised to do, especially for those kind of silent diseases such as high blood pressure. And then the impact of this particular level is also limited by imperfect effectiveness. So everything just doesn't work for everyone. And I think what's important to notice about this level is that it cannot be considered without the context of the previous levels before it. So that access, as we're seeing, that access is important in each of these levels as we go up the pyramid. And then finally, the highest tier would be education, counseling and education. And this is education provided during clinical encounters as well as education in other settings. That said, lots of times as providers, this is considered merely providing information without confirmation that patients really understand that, which brings me to my project particularly. And so, I know this is a Zoom presentation, but I want everyone to consider, who has ever traveled abroad? I've heard that the best way to learn a new language is to really travel to a country where that language is spoken and immerse yourself. And the advice is beautiful, but it dictates that you leave your English at home and you delve into a circumstance where you really understand nothing. And for anyone who has ever ventured into an experiment like this, I have, it's known that things are fine and dandy until you're in a very acute situation where it's pretty important that your needs are understood and that you understand the language of those around you. Without that understanding, it becomes very difficult to function. I want you to take this analogy and apply that to patients, because for many patients, that is the experience of coming into a physician or healthcare provider's office. The patient doesn't necessarily have the tools to function in that setting. And in the setting of a healthcare provider, that tool is health literacy. So health literacy is defined as personal characteristics and social resources that enable a person to be able to access, understand, appraise, and use information and services to participate in decisions related to their health. So there is an important interplay between those socioeconomic factors that we saw make up the biggest rung of that pyramid and health literacy. 2011 analysis found that disadvantaged social and socioeconomic conditions really do contribute to low health literacy, and that is a tremendous determinant of health literacy. So now we are going to have a poll, and I have a poll that should be loaded up. There we go. And we're going to give people about 30 seconds to answer these questions. And if anyone here is uncomfortable with awkward silences, believe me, it is much more pronounced in this setting, but I would like everyone to take about 30 seconds to answer this poll.
Well, I'm going to, just for our audience, because this is kind of a new thing for our webinars, and I'm excited that Jymirah has introduced this. So it's very easy and anonymous to do. Just answer the questions. I'm going to do it myself here. And and we'll see what we come up with. Thank you, folks. Oh, it looks like I can't vote, so we're depending on you to vote.
And so we'll give everyone about maybe 15 more seconds just to vote. Again, these answers are anonymous. And that'll be about it. We can go ahead and close the poll down for now. Okay. So I asked you all to do that because the Agency for Healthcare Research and Quality actually did a poll similar to this, where they asked people the questions that I asked. So, you know, whose healthcare provider gives easy to understand instructions? How many providers are asking how those instructions will be followed? Who feels that their providers listen carefully to them? And who's even being involved in the healthcare decisions? And as we can see just from this slide, I'll go through it quickly. All of those numbers are really below the target. In some cases, particularly where the healthcare provider is being, or where the patient is being involved in decisions, less than 50% of people feel that they're being involved in their decisions. And this is a pretty important kind of problem, and I'll discuss why in a minute. So we told the patients, why is it really our problem that they understand? Low health literacy contributes to 4 times higher healthcare costs, more hospital visits, longer stays when people are in the hospital, worse health outcomes, more mental distress, lower quality of life, and frankly, it's costing the healthcare system $236 billion annually. So our own doctors, Johnson and Nilsen, have conducted a study evaluating the health literacy of patients from our head and neck cancer survivorship clinic. And of the patients that were evaluated after adjusting for their age, marital status, and different factors such as time since completion, the scores for quality of life for the survivors who have adequate health literacy were almost 11 points higher than those with inadequate health literacy. So what that tells us is that inadequate health literacy is leading to lower quality of life in head and neck cancer survivors. So my project really gets at discussing healthcare literacy as well as caregivers. We would really be remiss in discussing any aspect of healthcare, particularly chronic, if we did not also include a discussion of those personal providers to patients. In the United States, there are about 40 million people who are serving as caregivers to adult care recipients. And these caregivers, particularly anyone who is a caregiver, you know that includes everything. That includes medical tasks, decision-making, particularly communicating with healthcare providers. And so we know that inadequate health literacy among patients is associated with low quality of life, but we don't know if the caregiver health literacy has any impact on the patient's outcome. And so it's important that these caregivers have the tools to interact with patients and providers alongside their care recipients. This data is really important because as we seek to improve outcomes in head and neck cancer survivors, we could be working against a really large barrier to the overall improvement of these patients' quality of life. But more so, we could be working against a barrier towards improving communication just between patients and providers in general. And so really to conclude, based on the results of this study, we're hoping to kind of tailor our interventions or how we move as clinicians to improve caregiver health literacy in our patient population. We do believe that there will be an association, but of course we have to wait for the data to show that. Although addressing health literacy is definitely at the top of that kind of pyramid, it's a more case-by-case undertaking than, let's just say, putting fluoride in the water. We owe it to patients to work at correcting one more barrier to the delivery and receipt of their healthcare. Any questions? If you have questions, put in the Q&A box.
Yeah, please, folks, put the questions in the Q&A. And Thank you, speakers. I'll tell you, this is, very interesting. And I'll tell you, all of our listeners, the Ioneer Foundation, of course, our focus is to really try to improve care, advance care for patients. And sometimes we can't overlook these things that are so incredibly important related to communication. Dr. Palmer's presentation related to communication and the fact that some people aren't communicating with their physicians because they can't hear them is something maybe that would be more obvious, but this is also very important. Are we communicating with our patients in terms of understanding some of the things that may be barriers to their communication other than their ability to hear? So very interesting. So please, folks who are, the Q&A is at the bottom. You can type in your question and then we'll be taking those for our panel. And thank you, panel, for providing this. I'll start off with a question. Are the communication struggles that we evaluate with patients, are they fairly universal for certain issues or maybe certain types of clinical visits, based on the complexity of the clinical visit? Are there differences based on, where people live or where people are from? Or is it, or do we need to improve that overall in terms of communication? I'll ask the panel. Oh, Jymirah, I think.
So I can start, and then I think Jymirah can add to it. So I think sometimes patients, one of the communication issues is that, providers have their perception of what a patient may need, and the patient has the perception of what is important to them. And we don't always exchange and meet up and really come to a recognition of what the patient really wants and needs. And it's been seen in a lot of different literature. So it's not just head and neck, but in other cancers, that we're not always on the same page with our patients.
So it's really a matter of as Jymirah pointed out, it is sort of taking the time to look at your patient and understand, that they really are understanding. Are there cues that are important to that you can then evaluate and look at whether the patient's nodding appropriately at the right time, or there's certain cues that you can look at that really know that you're making good communication?
Yeah, so actually that was a slide that I took out because the presentation was a little long, but there are definitely kind of informal ways of assessing if a patient's understanding. So for example, if you're talking to a patient and they maybe don't have a solid understanding of their healthcare issues, of the different problems that they have, if they identify their medications by the shape or the color, as opposed to what they're for, the name, that might tell you that they don't necessarily have an understanding of what exactly they're using the medications for. An example we have used in med school when we were practicing interviewing is, we'd come in and we'll ask someone, do you have any healthcare problems? And they'll say no. And then you'll ask, okay, what medications are you on? And they'll say insulin. And that's a solid kind of indicator that they don't understand that, diabetes is a problem, and they're not necessarily making that connection between the problem and maybe what they need care for.
Mm-hmm.
Well, we have some questions from our audience. If the trends of your study arrive as implicated, what do you think will be some plausible solutions for improving those outcomes?
Ooh, yeah, so part of my research as of right now is looking at what kind of measures have been taken to improve health literacy. I am a problem solver, so I of course have some ideas, but the way that things are run in the head and neck survivorship clinic is that, patients, get a battery of surveys, and that frustrates them a little bit because that's a lot of time and a lot of questions that they have to answer. But it really gets at, as Dr. Nilsen was saying, what's important to them. And so I think maybe kind of standardizing patient-reported outcomes as a means of, as a clinical visit. If we standardize that, then when the provider comes in and says, "How are you?" and the patient says, "Fine," then there won't be this disconnect. And then we can maybe have a better idea of what exactly the patients are struggling with that they don't necessarily have the means to articulate.
And
I think one of Jymirah's other parts is caregivers, and that's a dyadic relationship. So you both kind of go through cancer and its treatment, and as providers, we target patients. And so how are there ways for us to also, understand what the needs of the caregiver are? And some places, such as in gynecological cancers, there are areas that focus really just on caregivers and caregiver burden, trying to educate and teach them. So can we replicate something like that in head and neck and start from the beginning? And so that both are educated and, also try to continue to provide support as they go through their treatment. Because things arise all the time. And sometimes you don't know what's going to happen until it happens.
Well, and as I understand it, Jymirah mentioned, the patient says it's fine. I think that's kind of even the survivorship model in general is trying to get beyond where the patient just says, "I'm fine," as I hear Dr. Johnson say very frequently.
So
another question.
We continue to introduce new questionnaires in our clinic to explore new areas because, it's the patients who teach us where we're falling short. It's the patients who bring to us an awareness of what's important to them. So we really do need the patients and their caregivers to tell us. And these PROs, patient-reported outcomes, are the questionnaires that people get in our clinics. And the whole idea is to structure an understanding of where we could change, where we could help, how we could improve. That's what it's all about.
And my
Another
project
question.
particularly,
Sorry.
particularly gives some of those patient-reported outcomes to the caregivers so that we can see, are caregivers sleeping well? Are they also going through anxiety and depression while being providers, the off-duty providers for these patients?
Very good. So I have another question from one of our guests. A colleague of mine is 91 and is showing a need for hearing aids. He worries about the cost. What's a good way to convince him to get tested? I hear this quite often, and convincing people based on some of these things that we discussed and Catherine Palmer discussed, I think are very important. Dr. Johnson, you want to handle that one?
So, getting tested is relatively inexpensive. In fact, it's very inexpensive. But as Catherine pointed out in her talk, the average cost of a hearing aid in this country today is like over $2,000. But, we have alternative approaches to this. So, for instance, there's a device you put on your ears so you look like a 13-year-old, and it amplifies sound. Those devices, which are readily available, they do not require a prescription, cost roughly $45. So we actually have been distributing them in our survivors clinic because we've encountered lots of patients who have trouble hearing, and they also sometimes have trouble with their hearing aids. They don't like them. And this is such a simple device. Marci has a wonderful story about a man who bought 2 pair one day. How did that go, Marci?
So we had a gentleman who did not like his hearing aids, and that's one of the first things we do is we screen. And so he was interested in the Listenator, or the Super Ear, which is just a device that goes over your head like a headset, and it's got a little microphone. And by the end of the visit, he actually bought 2 because he was going through give one to his girlfriend so that they could go to the movies together and be able to do something like that. So I think when you talk about why hearing aids are important, I think the social isolation that can happen and the lack of interaction and communication when you have hearing difficulty. So if he's looking for reasons why, you know, being able to have a hearing aid and letting you hear your surroundings can help you engage with others. And it really is an important kind of social aspect. And it is important in medicine so that you can hear what your providers, you know, are trying to kind of tell you. So I think those are some of the reasons why, beyond going to the movies with your girlfriend and to be able to hear it. And I know there's another question related to cost, and you know, since we do have, Dr. Palmer has our audiology assistant in clinic, I do know that patients really do worry about the cost. And one of the nice things about getting screened is that, you know, the audiologists do know resources if you're really on a limited budget that may be able to help get hearing aids, like Catholic Charities and a couple others that do it. So they're really knowledgeable in that area. So if you're concerned about it, it really shouldn't stop you from at least inquiring about it, because they may be able to help and provide assistance.
So to answer that last question, I think you did in a sense, is to connect with an agency to help my mother get free hearing aids because she's on Social Security. The first step is getting screened and working with an audiologist, and particularly we know, of course, our audiology group is extremely good at helping find those resources. Some organizations like the Lions do provide some support for hearing aids, not necessarily free, but support to make them lower cost. But again, it starts with getting a hearing assessment with an audiologist. Am I correct?
I'm not an audiologist, but I would say that's what we do. So yes.
Okay. Well, thank you for presenting a very, very interesting and very important topic. And it is something that we're proud to support because, again, you know, we do all these wonderful things. We're developing all kinds of wonderful tools. She said she goes through UPMC at Shadyside. So we should, you know, maybe we'll follow up with this individual regarding that. But we're doing all this wonderful research to try to advance care. And we're doing a lot of things which we know will advance care. However, we want to make sure that we're communicating the needs of for our patients so that we can understand the best ways to help them. So I think the understanding of that and the research behind that to understand how we can do that better is very, very practical, very important. And I think was the message of today's program. So thank you all so very much. So with that, I'll wish you all a good rest of the afternoon.